Cancer loves acid. Cancer also loves no oxygen, an educator once said. Pause. Alexis saw a lump in her side. Doctors brushed it off. A year later, itchy legs. Then she couldn't stay awake past 6 in the evening. Night sweat so bad she'd soak through in the middle of summer. 4 symptoms. Nobody connected them, until a scan lit up like a warning sign, and the word came back: lymphoma. Here's what almost nobody tells you. Lymphoma isn't one disease, it's 2 completely different diseases wearing the same name. One of them is named after the doctor who first described it nearly 200 years ago. The other covers dozens of different subtypes, all with different personalities, different speeds, and different playbooks. One of them your doctor might tell you to simply watch. The other, they'll admit you to hospital for within days. And there's a third condition, one most people have never even heard of, that quietly raises your risk of developing lymphoma without you ever knowing you have it: Sjogren syndrome. By the end of this video, you'll know exactly what a doctor sees on a PET scan, how pathologists tell these 2 cancers apart under a microscope using a single type of cell, why one invisible line inside your body decides whether your cancer is called early or advanced, which chemotherapy combination has been curing Hodgkin lymphoma for decades, and why a dry mouth could be more connected to cancer risk than you'd ever imagine. Let's break it down, stage by stage, cell by cell. Before I continue, I've pulled real patient stories, real US data, and expert-backed diagnostic clues to help you figure out what your symptoms are really telling you. And if you want a link to access the symptom map, just type symptom map in the comments. I'll heart your comment and drop the link. Let's start with the basics, because most people get this wrong immediately. Lymphoma is a cancer of your lymphatic system. Your lymphatic system is a network you probably don't think about until something goes wrong with it. Glands running through your neck, your armpits, your chest, and your groin, all connected by a web of thin vessels that drain fluid around your body and carry your immune cells to wherever they are needed. Under normal circumstances, the lymph nodes scattered through that network are doing quiet, essential work, filtering fluid, housing immune cells, helping your body recognize and fight off infection. In lymphoma, something goes wrong at the cellular level inside one of those nodes. A lymphocyte, a type of white blood cell that's supposed to be part of your defense system, mutates, starts dividing uncontrollably, and instead of dying off the way old cells normally do, it keeps multiplying. That's what causes the swelling you feel under your skin. It's not fluid. It's not infection. It's an accumulation of cancerous immune cells. And here's the first thing that surprises people: lymphoma isn't one disease. There are 2 major families, and doctors treat them in genuinely different ways: Hodgkin lymphoma and non-Hodgkin lymphoma. They can look almost identical on the surface: swollen glands, fatigue, night sweats, weight loss. But underneath, they're driven by different cells, carry different risk profiles, and respond to different treatment plans. Getting that distinction right at diagnosis changes everything that follows: the tests, the staging conversation, the drugs, and ultimately, the outlook. So let's take them one at a time, starting with the one that carries a person's name. Hodgkin lymphoma gets its name from Thomas Hodgkin, a physician who first described this pattern of disease in the 1830s, making it one of the earliest cancers ever formally documented. It's actually the rarer of the 2 major lymphoma types, making up roughly 1 in 10 lymphoma diagnoses. But it has one of the most distinctive fingerprints in all of cancer medicine, and that fingerprint is what makes it so reliably diagnosable. When a pathologist looks at a biopsy under the microscope, they're hunting for one specific thing: a Reed-Sternberg cell. These are large, abnormal cells, often with 2 mirror image nuclei sitting side by side, which is why pathologists have described them for decades as looking like a pair of owl's eyes staring back through the lens. These cells actually start life as normal B lymphocytes, the same category of immune cell involved in non-Hodgkin lymphoma, but they undergo such significant genetic mutation that they lose the identity of a normal B cell entirely and transform into something structurally unique. If Reed-Sternberg cells are present in the tissue sample, that's the confirmation: this is Hodgkin lymphoma, not non-Hodgkin. That single cell type is the dividing line between the 2 diseases, and it's the reason Hodgkin lymphoma can usually be diagnosed with real confidence once a biopsy is in hand. Something else worth knowing: Hodgkin lymphoma isn't just one disease pattern either, it splits into subtypes of its own. The vast majority of cases, more than 9 in 10, fall under what's called classical Hodgkin lymphoma, which is further broken down by how the affected tissue looks under the microscope: nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted. There's also a rarer form called nodular lymphocyte-predominant Hodgkin lymphoma, which behaves more slowly, tends to affect a slightly different patient group, and is treated somewhat differently because it carries a different variant of that same abnormal cell. Who tends to get it? Hodgkin lymphoma has a distinctive age pattern that doctors call bimodal. It spikes first in young adults, typically in their 20s, then has a second, smaller spike in people over 60. That first peak is part of why it shows up so often in teenagers and young adults, similar to the 17-year-old you heard about earlier. Other recognized risk factors include a prior Epstein-Barr virus infection, the virus responsible for glandular fever, having a first-degree relative who's had Hodgkin lymphoma, and having a weakened immune system, including from HIV. The symptoms overlap heavily with what we'll cover in the next section: painless swelling in the neck, armpit, or groin, plus what doctors call B symptoms: fevers, drenching night sweats, and unexplained weight loss of more than 10% of body weight over 6 months. There's one more symptom that's more specific to Hodgkin worth knowing. Some patients develop persistent itching, particularly after bathing or after drinking alcohol. That's exactly the itchy leg symptom you heard about in the earlier patient story, and it's a detail a lot of people never think to mention to their doctor, because on its own, it just seems like dry skin. Here's the part that matters most if you or someone you love is facing this diagnosis. Hodgkin lymphoma is one of the most curable cancers in modern medicine. Even in advanced stages, it responds extremely well to treatment. Overall 5-year survival rates sit around 89%, and for patients diagnosed at an early stage, cure rates run considerably higher than that. Treatment typically follows a well-established chemotherapy regimen, most commonly a 4-drug combination that oncologists refer to by the acronym ABVD, sometimes combined with radiotherapy for localized disease, following the exact same staging logic we are about to cover, using the diaphragm as the dividing line between early and advanced stage. In cases that don't respond to standard treatment, or that relapse afterward, doctors now also have immunotherapy and stem cell transplant options available, the same categories of treatment you'll hear about in detail in the non-Hodgkin section. Non-Hodgkin lymphoma is the more common of the two by a wide margin, accounting for roughly 90% of all lymphoma diagnoses. And it's really an umbrella term, not a single disease. It covers dozens of different subtypes, all defined by which specific immune cell went wrong, and how aggressively that cell is behaving. Some of the more commonly diagnosed subtypes include diffuse large B-cell lymphoma, which is the most common form overall and tends to be fast-growing, follicular lymphoma, which typically behaves more slowly, and MALT lymphoma, which develops in mucosa-associated lymphoid tissue and is particularly relevant later in this video, because it's the subtype most closely linked to Sjogren syndrome. Unlike Hodgkin lymphoma, there's no single telltale cell like the Reed-Sternberg cell to look for. Instead, diagnosis comes down to 2 questions doctors ask about every case: is it low-grade or high-grade, and is it localized or advanced? Those 2 answers are what build the entire treatment plan, and that's what the rest of this video focuses on in real detail. Before we move into symptoms, it's worth answering the question a lot of people ask right after hearing all this: why does this happen, and who's more likely to get it? For non-Hodgkin lymphoma specifically, doctors have identified several recognized risk factors, though it's worth saying upfront that many patients have none of them. This disease can affect people with no clear risk factor at all. Age is the biggest one. Risk climbs steadily as you get older, with most diagnoses happening in people over 60. A weakened immune system raises risk significantly. This includes people on long-term immunosuppressant medication after an organ transplant, and people living with HIV. Certain infections are linked to specific subtypes: Epstein-Barr virus, Helicobacter pylori, the bacteria behind most stomach ulcers, which is specifically linked to MALT lymphoma of the stomach, and hepatitis C have all been connected to elevated risk. And, as we are about to cover in depth, autoimmune diseases, Sjogren syndrome most of all, but also rheumatoid arthritis and lupus to a lesser degree, raise risk through chronic immune overstimulation. For Hodgkin lymphoma, the picture is a little different, which is part of why doctors think about it as a genuinely separate disease rather than just the other lymphoma. The bimodal age spike we covered, young adults in their 20s, then a second peak after 60, doesn't follow the same steady climb with age pattern that non-Hodgkin does. Epstein-Barr virus shows up here too as a risk factor. Having a sibling with Hodgkin lymphoma modestly raises your own risk, pointing to some genetic component, though it's not considered a strongly hereditary cancer. And, as with non-Hodgkin, immune suppression from HIV or other causes increases risk. None of these risk factors are things most people can meaningfully control, and that's worth saying plainly. This isn't a lifestyle disease in the way some cancers are discussed. That's exactly why symptom awareness matters more here than in almost any other cancer type. You can't screen for lymphoma the way you'd get a mammogram or a colonoscopy, because there's no routine population-wide screening test for it. Recognizing the symptoms early is, for now, the closest thing to prevention that exists. This is where both types of lymphoma become genuinely dangerous, because on their own, none of these symptoms scream cancer. They scream I'm run down, or I probably just have a virus. Doctors say the classic warning signs, common to both Hodgkin and non-Hodgkin lymphoma, are a painless swelling or lump, usually in the neck, armpit, or groin, that just doesn't go away and doesn't shrink after a couple of weeks. High fevers that come and go for no clear reason, sometimes cycling in a pattern over days or weeks. Drenching night sweats, not just a bit warm, but soak through the sheets sweating that wakes you up needing to change your clothes. Unexplained weight loss, losing a meaningful amount of body weight without dieting or increasing exercise. Unusual bruising or bleeding, bruises that appear without an obvious cause, or bleeding gums. Recurrent infections that keep coming back, because the disease is starting to interfere with normal immune function. Persistent fatigue severe enough to interfere with normal daily activity. And for Hodgkin specifically, itching, especially after alcohol or a hot bath. One patient I want you to hear about, she was 17. Just started sixth form, just started a part-time job, completely normal life. Her first symptom was a lump in her side. She went to the doctor. It was brushed off, which, to be fair to doctors, is understandable, because a single painless lump in a healthy teenager doesn't usually ring alarm bells on its own. A year passed. Then her legs became unbearably itchy. Then the fatigue hit, falling asleep at 5 or 6 in the evening, every single day. Night sweats she blamed on summer heat. It was only when all 4 symptoms stacked up together, the lump, the itching, the sweats, the exhaustion, that anyone put the picture together. That's how lymphoma hides, whichever type it turns out to be. Not as one dramatic symptom, but as a slow accumulation of things you individually explain away. That's exactly why doctors want you to come in when 2 or more of these symptoms show up together, even if each one alone feels minor. Once lymphoma is suspected, of either type, here's the actual diagnostic pathway doctors follow, step by step. Step 1, blood tests. These give an initial picture of your overall health, your blood cell counts, and markers that can suggest something is going on, though blood tests alone can't diagnose lymphoma. Step 2, a PET scan. This is the tool that changes everything. A PET scan works by injecting a small amount of a radioactive tracer attached to a sugar molecule into your bloodstream. Cancer cells, because they are dividing so rapidly, burn through sugar at a much higher rate than normal cells, so they absorb more of that tracer, and they light up brightly on the scan. A PET scan doesn't just show where your lymph nodes are, it shows how metabolically active they are. Areas that are lit up brightly are the areas doctors get concerned about, because that activity can signal cancer. This applies whether doctors are working through a Hodgkin or non-Hodgkin case, it's the same starting tool for both, and it's also highly sensitive for picking up bone marrow involvement, which matters for staging. That scan does something else critical. It tells doctors exactly which glands to biopsy. Instead of guessing which of potentially dozens of swollen nodes to sample, they target the specific lit-up node, the one most likely to give a clear, accurate diagnosis on the first attempt. Step 3, the biopsy. Doctors take a tissue sample, usually a core biopsy, sometimes a full lymph node removal if the tissue architecture needs to be preserved for accurate diagnosis, and examine it under a microscope, along with specialized staining techniques that highlight specific proteins on the cell surface. This is where the 2 diseases split apart. If they find Reed-Sternberg cells, it's Hodgkin. If they don't, it's non-Hodgkin, and the next question becomes, is this a low-grade or high-grade lymphoma? Low-grade means the cancer cells are dividing slowly, a generally slower-moving disease that can sometimes be monitored rather than immediately treated. High-grade means the cells are dividing rapidly, more aggressive, more likely to cause symptoms quickly, and it changes the entire treatment plan toward more immediate, more intensive intervention. Here's the part almost nobody outside medicine understands, and it applies to both types of lymphoma. Your diaphragm, the muscle that separates your chest cavity from your abdominal cavity, is the anatomical line doctors use to stage lymphoma. This comes from a staging framework called the Inaba system, which most hematologists still use as their starting point today. Stage 1, early, localized. Cancer is found in a single lymph node region, or a single organ outside the lymphatic system. Stage 2, cancer is found in 2 or more lymph node regions, but all of them are on the same side of the diaphragm, so still confined to either above or below that line. Stage 3, advanced. Cancer is now found in lymph node regions on both sides of the diaphragm, above and below. Stage 4, the most advanced stage, cancer has spread beyond the lymph nodes into other organs, such as the bone marrow, liver, lungs, or central nervous system. Doctors will also often add a letter to your stage, an A if you have no B symptoms, or a B if you do have those fevers, night sweats, and weight loss we covered earlier, because the presence of B symptoms itself carries meaningful information about how the disease is behaving. So in simple terms, on the PET scan, early stage lymphoma shows glands lighting up mainly above the diaphragm, armpit, neck. Advanced stage lymphoma shows glands lighting up both above and below, abdomen and groin as well as the neck and armpit. One line. One scan. And it determines whether you're heading into watch and wait, localized radiotherapy, or hospital-based, intensive systemic treatment. This is the part that surprises people most about non-Hodgkin lymphoma specifically. There isn't one treatment protocol. There are at least 4 different parts, depending on grade and stage, and the right path for one patient could be completely wrong for another with a differently graded, differently staged version of what sounds like the same disease. First, early stage, low grade. Sometimes the plan is simply to watch and wait, monitoring you closely over time with regular checkups and scans, without starting immediate treatment. This surprises a lot of people, because watch and wait sounds passive when you've just been told you have cancer. But for slow-growing, localized disease, studies have shown that starting treatment immediately doesn't improve outcomes compared to closely monitoring and only treating once the disease shows signs of progressing or causing symptoms. If it's localized, say in the neck, doctors might instead use targeted radiotherapy from the outset. Radiotherapy uses a carefully calculated beam of high-energy rays aimed directly at the cancer cells, damaging their DNA so they can no longer divide. The catch, because it's localized to an area, some healthy cells nearby get caught in that beam too. That's exactly why people getting radiotherapy to the neck can experience fatigue, skin irritation, and a sore throat. It's not a flaw in the treatment, it's collateral, because those healthy cells simply happen to be sitting in the target zone, and the body needs time to repair that incidental damage afterward. Second, early stage, high grade. This calls for chemotherapy. And here's what chemotherapy is actually doing inside your body. It's designed to kill cells that divide quickly, which is exactly what cancer cells do. The problem is, some of your healthy cells also divide quickly as part of their normal function. Cells lining your mouth, your gut, your hair follicles, your bone marrow. Chemotherapy drugs generally can't distinguish between a rapidly dividing cancer cell and a rapidly dividing healthy cell. That's precisely why people get mouth soreness, nausea, hair loss, and bowel issues during treatment. It's not a random side effect profile, it's the drug doing its intended job on the wrong population of cells too, alongside the right one. Third, advanced stage, low grade. Doctors typically combine multiple types of chemotherapy drugs together, often alongside steroids, to bring the disease under control across the whole body rather than a localized area. Steroids are added partly because they have their own cancer cell killing effect on lymphoid tissue, and partly because they help manage inflammation and some of the side effects of the other drugs. Fourth, advanced stage, high grade. This is the most intensive path. Patients are often admitted to hospital and given aggressive, multi-drug chemotherapy regimens designed to kill the cancer cells fast, before the disease can progress further, sometimes combined with steroids and immunotherapy. Immunotherapy works on a completely different principle from chemotherapy. Instead of a blanket attack on any fast-dividing cell, it works by inducing your own immune cells to produce antibodies engineered to recognize and bind to specific markers found on the surface of the cancer cells. Because those antibodies are targeted, they leave your healthy cells largely untouched, which is why immunotherapy tends to come with a noticeably different, often gentler, side effect profile compared to standard chemotherapy. In some advanced or high-risk cases, radiotherapy is added back in too, depending on exactly where the lymphoma is sitting in the body and whether there's a dangerously located mass that needs direct, localized treatment. For the most intensive relapsed or aggressive cases, in both Hodgkin and non-Hodgkin disease, doctors may also turn to a stem cell transplant. There are two main types: an autologous transplant, where doctors collect and later reinfuse the patient's own stem cells after a round of very high-dose chemotherapy has wiped out the cancer, and unfortunately, the healthy bone marrow along with it, and an allogeneic transplant, where the stem cells come from a matched donor instead. The goal in both cases is the same: to let the very highest, most effective doses of chemotherapy be used, doses that would otherwise permanently destroy the patient's bone marrow, and then rebuild a healthy blood and immune system afterward using those transplanted stem cells. I want to bring this back to the 17-year-old from earlier, because her story shows exactly how this disease, and its treatment, evolves over years, not weeks, and how the same person can face multiple rounds of very different treatment as medicine advances and as their disease responds or relapses. Over roughly a decade, she went through 6 months of chemotherapy the first time. Then, when the disease returned, chemotherapy again, this time combined with a stem cell transplant using her own cells, an autologous transplant, in the terms we just covered. Then, years later, when it came back a third time, targeted antibody chemotherapy, immunotherapy, and high-dose chemo before a donor stem cell transplant, an allogeneic transplant, using a matched donor's cells to rebuild her immune system from the ground up. Here's the detail that matters most. The earlier chemotherapy, from a decade ago, hit her far harder: severe mouth ulcers, sickness, constant exhaustion, the kind of side effects that come from broader, less targeted drugs. But the newer treatments, especially the immunotherapy, came with noticeably fewer side effects. No sickness. Manageable fatigue. Still some mouth ulcers, but nothing like before. That's not a coincidence. That's the real-world shift from blanket chemotherapy toward more targeted, precise treatment that medicine has been moving toward for years, and it applies to both Hodgkin and non-Hodgkin patients alike, and increasingly to relapsed cases that would once have had very few remaining options. It's also worth being honest about the parts of this that don't show up in a treatment timeline. Repeated rounds of chemotherapy and stem cell transplants take a real toll, not just physically during treatment, but afterward. Long-term survivors of both Hodgkin and non-Hodgkin lymphoma are typically monitored for years afterward for potential long-term effects of treatment, including effects on fertility, heart, and lung function from certain chemotherapy drugs, and a small increased risk of secondary cancers later in life. This is exactly why doctors weigh treatment intensity so carefully against the stage and grade of disease. The goal is always to use enough treatment to cure the cancer, without using more than necessary. Today, she's been in remission for 2 years. Back at work. Booking holidays. Her hospital appointments have gone from constant to once a year, which, after a decade of treatment, is its own kind of milestone. There's an emotional dimension here that's easy to skip past when you're focused purely on the medicine, but it matters just as much. She described it herself. When you've spent that much time in hospital, you spend a lot of that time simply dreaming about what ordinary life will look like again, going back to work, being able to book a holiday without checking it against a treatment calendar first, not needing to explain your medical history at the start of every new relationship or job. Remission isn't just a blood test result. For a lot of long-term patients, it's the slow, sometimes disorienting process of learning how to live a normal life again after years of your entire identity being organized around treatment. That's part of why patient support organizations, cancer charities, patient helplines, and support groups specifically for lymphoma or for young adults with cancer, exist alongside the medical treatment itself, not as an afterthought to it. Now here's the piece almost nobody puts together. Sjogren syndrome is an autoimmune disease, meaning your immune system mistakenly identifies part of your own body as a threat and attacks it. Specifically, it targets your moisture-producing glands, most commonly your tear glands and salivary glands, causing dry eyes and a dry mouth as the hallmark symptoms. For a lot of people, that's where it seems to stop, an uncomfortable, chronic condition affecting quality of life, but nothing more sinister than that. But underneath, something else is happening. In Sjogrens, immune cells infiltrate those glands and cause ongoing, low-grade inflammation. Specifically, a type of immune cell called B lymphocytes, the same family of cells involved in non-Hodgkin lymphoma, become chronically overactive in this environment. Normally, old lymphocytes die off on a fairly predictable schedule and get replaced by new ones. In Sjogrens, they're stuck in a state of constant stimulation, continually activated by the ongoing autoimmune process. And sustained, prolonged overstimulation of those B cells is exactly the kind of environment that can eventually set the stage for lymphoma to develop, specifically non-Hodgkin lymphoma, and specifically MALT lymphoma, which develops in the mucosa-associated lymphoid tissue exactly where this chronic gland inflammation is already happening. That's not a coincidence of biology, it's a fairly direct line from chronic overstimulation to malignant transformation, which is why Sjogren's is considered the autoimmune disease with the single highest lymphoma risk of any of them, higher than rheumatoid arthritis or lupus, both of which carry some elevated risk too, but nowhere near this level. Some of the earliest studies on this estimated the risk at up to 44 times higher than the general population, a number that, understandably, sounds terrifying if you or someone you know has been diagnosed with Sjogren's. But more recent, larger studies have brought that figure down to a more realistic 6 to 9 times higher risk. Other research puts lifetime risk somewhere in the range of 5 to 15% for Sjogren's patients overall. And critically, however you frame the multiplier, the overwhelming majority of people living with Sjogren's never develop lymphoma at all. Doctors have also identified specific features that push an individual Sjogren's patient into a high-risk category, things like persistently swollen salivary glands, low complement levels on blood tests, and certain antibody patterns. Patients with those higher-risk features are typically monitored more closely, with more frequent check-ins and blood work. If you have Sjogren's, the message isn't panic, it's awareness. The same red flag symptoms we covered earlier for lymphoma apply directly here: persistent, painless swelling in the neck, underarms, or groin, unexplained fevers, drenching night sweats, unexplained weight loss. If any of those symptoms show up on top of your existing Sjogren's symptoms, which, to be fair, already include fatigue and joint pain, making it genuinely harder to tell what's Sjogren's and what might be something new, that's the moment to get it checked with your doctor, not months later. Let's clear up a few things people consistently get wrong about lymphoma, because misinformation here genuinely delays diagnoses. Myth: if it doesn't hurt, it's not cancer. The opposite is often true with lymphoma. The single most common early warning sign, a painless swelling, is painless specifically because of how these cells grow. Painful lumps are actually more often linked to infection. Doctors want you to get a persistent painless lump checked precisely because it doesn't hurt. Myth: a lymphoma diagnosis means the same treatment for everyone. As you've just seen across this entire video, that's about as far from true as possible. Two people with lymphoma written on their chart can be on completely different treatment paths, watch and wait versus hospital admission, depending on type, grade, and stage. Myth: chemotherapy side effects mean the treatment isn't working. Side effects are a sign the drug is doing exactly what it's designed to do, targeting rapidly dividing cells. It's an unfortunate side effect of how these drugs work, not a sign of failure. Myth: Sjogren syndrome is just dry eyes and a dry mouth. As you now know, it's a systemic autoimmune condition with real, measurable downstream effects, including that elevated lymphoma risk. It deserves ongoing medical attention, not just symptom management for the dryness. So here's what I want you to walk away with from everything we just covered. Lymphoma comes in two major forms: Hodgkin, identified by a single distinctive cell under the microscope and highly curable even in advanced stages, and non-Hodgkin, a broader family of dozens of subtypes where grade and stage decide the entire treatment path, from simple monitoring all the way to stem cell transplant. The most common first sign of either one is a painless lump in the neck, armpit, or groin. If you add drenching night sweats, unexplained weight loss, persistent itching, or bruising you can't explain, don't wait on that. And if you or someone you know has Sjogren syndrome, know that the connection to lymphoma exists and is well documented, but know that the actual real-world risk is far lower than the scariest headline numbers suggest, and that most people with Sjogren's live full lives without ever developing it. Always speak to your doctor if something doesn't feel right. Early detection is, quite literally, the single biggest factor in outcome, for both of these diseases, and for the condition that can quietly connect to them. If this broke something down for you that you'd never fully understood before, that's exactly what this channel is for. Subscribe, and I'll see you in the next one.